Dr. A.N. Roy. Thank you. I'll go one by one. So, what is heart failure with the preserved ejection fraction? We all know there are three types of heart failure related to ejection fraction. One is preserved, that is 50%, mid-range 40 to 50%, reduced is less than 40%. The heart failure with the preserved ejection fraction, that is previously termed as diastolic heart failure. The diastolic dysfunction is a functional abnormality of diastolic relaxation, filling, or distensibility of the left ventricle. The diastolic dysfunction of and heart failure with the preserved ejection fraction are not rather synonymous terms. So I closed the video because of the internet problem to be on the safer side. So the definition is the signs and symptoms of congestive heart failure: normal or near normal left ventricular ejection fraction, 50% more than, evidence of left ventricular diastolic dysfunction, that is echo, LV diastolic dysfunction, left atrial enlargement, left ventricular hypertrophy, and cardiac cath is elevated left ventricular end diastolic pressure. So the differential diagnosis of heart failure with the normal ejection fraction, the heart failure with the preserved ejection fraction contributing factors includes hypertension, one, aging, coronary artery disease, diabetes, obstructive sleep apnea, chronic kidney disease, obesity, cardiomyopathies with normal ejection fraction, restrictive cardiomyopathy, may be familial, systemic sclerosis, endomyocardial fibrosis, carcinoid syndrome, metastatic cancer, radiation, iron overload, hypertrophic cardiomyopathy.
Yes,
Next
Suji.
is next is valvular heart disease, stenosis, or regurgitation. The right heart failure, pulmonary hypertension, right ventricular infarct, arrhythmogenic right ventricular cardiomyopathy. The pericardial disease, that is the tamponade constrictive pericarditis. Obstructive lesions, atrial myxoma, pulmonary vein stenosis. Next is high output heart failure. So the prevalence 20 to 60% of patients with heart failure, increasing prevalence, asymptomatic diastolic dysfunction, much more common than heart failure preserved ejection fraction. Does not indicate heart failure preserved ejection fraction unless clinical syndrome of heart failure rather present. The LV diastolic pressure, the volume of blood in the left ventricle, the compliance of the left ventricle, the degree of external pressure applied on the left ventricle by pericardium and right heart chambers. So this is the left ventricular diastole. You can see the pulmonary vein, pulmonary capillaries, and pulmonary capillary wedge pressure. If it is more than 25 millimeter of mercury, that is pulmonary edema. 3 to 12 is normal, 12 to 25 is just elevated. So this is the cycle we all know, left ventricular diastole, very much know this is the base. The pathophysiology of heart failure with preserved ejection fraction, the chamber remodeling, most have concentric pattern of LV remodeling and a hypertrophic process rather. The normal or near normal end diastolic volume, increased wall thickness and or LV mass, an increased ratio of myocardial mass to volume, an increased relative wall thickness. At the cellular level, what happens? The cardiomyocytes increase in diameter but not in length. That is tight in hypophosphorylation. That is the latest thing. Increase in collagen and increase in fibrillar components of extracellular matrix. This is the pathophysiology, how it occurs in systolic heart failure, normal heart, and diastolic heart failure. This is how the microscopical picture occurs. So the major abnormalities of a left ventricular diastolic function, it showed delayed and incomplete myocardial relaxation. Number two, impaired rate and extent of LV filling, decreased early diastolic suction and recoil, an increased dependence on LV filling from atrial contraction, and increased left atrial pressure during the early filling, and increased passive stiffness rather, and decreased distensibility of the left ventricle. And there is a reduced ability to augment relaxation during exercise. and increased diastolic left ventricle, left atrium, and pulmonary venous pressure. So the non-diastolic mechanism in heart failure is preserved ejection fraction. The first and foremost is abnormal systolic function. By definition, EF normal. Tissue Doppler and strain imaging have shown impaired systolic function. Decreased longitudinal contraction 1. 2. Decreased motion of the basal left ventricular region of the mitral annulus. Third is worse outcomes. And endothelial and vascular dysfunction. The first point is endothelial dysfunction common in obesity, insulin resistance, hypertension, aging. Endothelial dependent vasodilatation, impaired and heart failure preserved ejection fraction, severity associated with more heart failure symptoms, worse exercise capacity. So the clinical presentation, the signs and symptoms, heart failure with preserved ejection fraction, heart failure with reduced ejection fraction. That is dyspnea on exertion 60% HFpEF, whereas 73% HFrEF. Nocturnal dyspnea is 55% in HFpEF. Heart failure with reduced ejection fraction, it is rather 50%. And lower extremity edema, it is 35% in heart failure with preserved ejection fraction, whereas heart failure with reduced ejection fraction, 46% is more. And the ROLS. Then heart failure is preserved, it is rather almost same, 72%, and HFpEF, whereas HFrEF, it is 70%. What are the common precipitants of exacerbation? The atrial fibrillation, we all know normal, regular, coordinated, sequential rhythm of atria is lost. That is loss of atrial contraction and tachycardia. Elevation in blood pressure, increase in LV wall stress as impairs myocardial relaxation. Ischemia worsens diastolic dysfunction, so rises the left atrial and pulmonary venous pressure. The dietary indiscretion, use of non-steroidal anti-inflammatory drugs, medication non-compliance, worsening renal function, then infection. So the diagnosis is non-dilated left ventricle with the left ventricular ejection fraction more than 50%. The clinical signs and symptoms of heart failure, three or more of the following criteria: typical demographics, one or more, age more than 60, obesity, female, hypertension, diabetes. Suggestive findings on echo, LVH, evidence of diastolic dysfunction, LV enlargement, elevated, that is pulmonary artery systolic pressure, elevated brain natriuretic peptide, peak VOT and less than 80% predicted, elevated left ventricular diastolic pressure. How to make the diagnosis, that is HF, that is PEF, H2F, PEF score by mnemonics, let us see. This is H2F PEF score by mnemonics. This is a properly validated diagnostic algorithm with preserved ejection fraction. You can see. So H2FPF risk score ranging from 0 to 9 points. H2 heavy, body mass index more than 30 kilogram per square meter, 2 points. That is first H. Hypertension, 2 medications or more than 2 medications, that is 1 point. That is the second H stands for. Then F, that is fibrillation, atrial, paroxysmal or persistent, 3 points. P stands for pulmonary hypertension, pulmonary artery systolic pressure, more than 35 millimeters of mercury by echocardiography, 1 point. Elder, age more than 60 point, 1 point. Filling pressure more than elevated, Doppler capital E, small e, that is ratio 9, more than 9, that is 1 point. This is H2F PEF score by mnemonics. So how do you evaluate the patient? History and physical examination, laboratory, chest, ECG, echo, evaluation of coronary artery disease. Keep that. Prognosis, annual death, that is about 5%, 50% die of non-cardiovascular disease. Risk factors for mortality in HFpEF, increasing age, male gender, higher brain natriuretic peptides, higher New York Heart Association class, coronary artery or peripheral vascular disease, DM, then chronic renal insufficiency, lower EF restrictive filling pattern on Doppler echo, low and very high BMI, that is in heart failure with preserved ejection fraction. How do you treat the patient? Many of the same drugs are used, but evidence differs. Use of same drugs As for heart failure with reduced ejection fraction, justified because of the comorbid conditions like atrial fibrillation, hypertension, diabetes, coronary artery disease. Heart failure with preserved ejection fraction focus, symptoms relief, BP control, heart rate control, treat myocardial ischemia. What are the treatment options? Symptom relief BP, heart rate control, treat myocardial ischemia. Non-pharmacological, sodium fluid restriction, regular exercise, weight loss, treatment of obstructive sleep apnea, volume overload symptoms, diuretics, be especially consider mineralocorticoid receptor antagonists. Hypertension, so keep an eye, ACE inhibitors, ARBs, beta blockers. Atrial fibrillation, again beta blockers, non-dihydropyridine, calcium channel blockers, verapamil, diltiazem. Then digoxin, YAC, restoration of that is SR when possible, and diabetes, ACE, ARBs, statin. Coronary artery disease, ACE, ARBs, beta blockers, statin, revascularization when appropriate. Nitrates is doubtful. So there is one entity called reduced lap heart failure trial. Transcatheter intracardiac shunt device provides sustained clinical benefit at 1 year in heart failure with preserved or mildly reduced ejection fraction. This is reduced lap heart failure trial. So this is the elevated LV filling, pressure elevated lap, that is pulmonary venous hypertension, results in pulmonary congestion and dyspnea at rest or exercise. You can see on the left side the diagram very well. So this is the MACE events, how it occurs in 6 months and 1 year, and effectiveness 6 months and 1 year. This is the safety, and this is the device patency confirmed in 54 subjects by echo or oximetry. So it is proved somewhat beneficial. So these are all the current tracks. There is so many current clinical trials. That is Algebrium trial, that is Anakinra trial, then HISDN trial, LCS, so many trials with preserved ejection fraction. There are so many trials, and what are the drugs they are used. So the LV diastole begins with the relaxation of the contracted myocardium, dynamic energy dependent process, two phases, isovolemic relaxation, exotonic relaxation, rapid pressure decay associated with untwisting and elastic recoil. It produces a suction effect promoting left ventricular filling by increasing the left ventricle left atrial pressure gradient. So it pulls blood into the left ventricle. The process augmented during exercise to compensate for reduced diastolic filling time. And later phases of diastolic cardiomyocytes are relaxed and normal LV is compliant and readily distensible. The atrial contraction 20 to 30% of total LV filling volume that increases the pressure more than 5 millimeters of mercury. What is the role of titin? The giant elastic protein expressed in cardiomyocytes in two isoforms, that is N2B, that is a stiffer spring, and N2BA, that is a more compliant spring. The titin functions as a bidirectional spring responsible for early diastolic LV recoil and late diastolic resistance to stretch. So titin is compressed within when the myocyte shortens during systole. At the beginning of cell relaxation, the compressed titin forcefully expands and generates an intracellular restoring force that re-lengthens the sarcomere and myocyte. So isoform expression of titin differs in patients with systolic heart failure and diastolic heart failure. In patients with systolic heart failure, titin isoform expression shifts towards the more compliant isoform, whereas in patients with diastolic heart failure, the shift is towards the less compliant isoform. Please note. So this is the pathophysiology which I have highlighted. This is the depicted diagrammatic one. So role of brain natriuretic peptide, that is levels usually lower in heart failure, preserved ejection fraction than heart failure with reduced ejection fraction. If elevated, strong independent predictors of clinical events in heart failure with preserved ejection fraction. No concerns on use to gauge medical therapy. That is natriuretic peptide, brain natriuretic peptide, more sensitive and falsely negative in up to 20% with heart failure with preserved ejection fraction. Does not correlate well with symptoms. So this is the thing, and this is the mode of death in heart failure, preserved ejection fraction with heart failure with the reduced ejection fraction. That is the mode of death. That is sudden death, sudden heart failure, myocardial infarction, stroke, non-cardiovascular, preserved and reduced ejection fraction. This is the comparative percentage. So all treatments are empiric. Please note, 2013 ACC/AHA guidelines supports four treatment of choice: control of systolic and diastolic hypertension, control of atrial rate in patients with atrial fibrillation, control of pulmonary congestion and edema with diuretics, coronary revascularization of patients with coronary artery disease where ischemia causes worse diastolic function. So thank you very much. I think I have completed before time. Thank you.
Thank you very much, sir. As expected, it was brilliant, super, fantabulous. And it went on very smoothly, very well. Now, do we have any time, Dr. Birmani?
You can ask one or two questions. One or two
1
questions,
hour.
sir.